Welcome, future clinicians. So, picture this. A patient has just had their very first seizure. Their life might be about to change, and they are looking right at you for the answer. Now, choosing their first anti-seizure medication is one of the most common and most critical decisions you're going to make in neurology. Let's make sure you're ready for it. So here's our game plan for today. First, we're going to tackle that big question. Do we even treat at all? Then we'll get into the pharmacy, so to speak, and look at the main tools we have. After that, it's all about matching the right tool to the right seizure, and then, even more importantly, to the right patient. And finally, I'll give you a simple framework to put it all together. All right, first things first. Before we even think about writing a prescription, we have to ask a much more fundamental question. Should we even treat? This isn't just a clinical decision. For the patient, this can be a life-altering one. It all comes down to balancing the risks and the benefits. This is a scenario you are going to face over and over again. A patient is in your ER, they've just had their first ever seizure. They're terrified, the family's in shock, and everyone wants to know, what now? I mean, starting a medication could mean a lifetime of therapy. So the answer isn't a simple yes or no. It's about becoming a bit of a detective and figuring out their risk for having another one. Okay, this algorithm might look a little complicated, but honestly, it boils down to just one question. How likely is this to happen again? And we don't guess, we look for clues. As you can see here, we're looking for things like a prior brain injury, or maybe some of those epileptiform spikes on their EEG. If we find those high-risk features, their chance of having another seizure jumps to over 60%. At that point, yes, starting an anti-seizure medication, or ASM, becomes the really clear choice. But if those risk factors aren't there, we can often just safely wait and see. Okay, so you've made the call. You're going to treat. Now what? Well, the single most important concept that's going to guide almost all of your initial choices is the drug's spectrum of activity. If you get this right, you are well on your way to making a great choice. Think of it like this. You've got a master key versus a specific key. Broad-spectrum agents, that's your master key. They work on lots of different seizure types, both focal and generalized. Narrow-spectrum agents, they're specialists. And this distinction is absolutely critical, because if you give a narrow-spectrum drug to a patient with a generalized epilepsy, you can actually make their seizures worse, a lot worse. So this table shows our go-to players. In that broad-spectrum column, you're going to see levetiracetam and lamotrigine everywhere. They're basically the workhorses of modern neurology. Valproate is in there too. It's incredibly effective, but it has some serious issues we'll get to in a minute. For focal seizures, the carbazepine family and lacosamide are classic choices. And then you've got ethosuximide, all by itself in its own category, because it is the undisputed champion for one very specific type of seizure, absent seizures. You need to commit these names to memory. You'll be seeing them a lot. Okay, theory is great, but let's make this practical. How does this whole spectrum idea actually translate to you writing a prescription? Let's walk through the most common seizure types you're going to see on the words. So, if your patient's seizures start in one specific spot in the brain, what we call focal seizures, you'll be reaching for one of these guys. Levetiracetam is often a favorite because you can get to a therapeutic dose really fast. Lamotrigine is another excellent choice, but you have to go slow with it, titrate it up over weeks to avoid a potentially serious rash. And carbamazepine, it's a classic, very effective, but boy is it notorious for interacting with a ton of other medications. Now, for generalized tonic-clonic seizures, the kind that involves the whole brain right from the start, you absolutely must use a broad-spectrum agent. Using a narrow-spectrum drug here could be a disaster. Valproate is incredibly effective, but it comes with a huge warning sign. It is highly teratogenic. It has the highest risk of causing birth defects of all the ASMs. This is so important. For any female of childbearing potential, you pretty much always avoid valproate, which is why levetiracetam and lamotrigine are much more common first-line choices. And what about absent seizures? Those brief staring spells you often see in kids? It's simple. Ethosuximide is king. It is the specific narrow-spectrum drug of choice, period. It works great for this seizure type, and it's generally really well tolerated. So, we've matched the drug to the seizure. Now we have to do something even more important. We have to match the drug to the unique human being sitting right in front of us. And this, my friends, is where medicine really becomes an art. Look, every single medication is a trade-off, and this is the conversation you have to have with your patient. With levetiracetam, you've got to warn them about potential irritability or mood changes. With lamotrigine, it's about dizziness, maybe some vision changes. And with valproate, you have to talk about the real possibility of weight gain and hair loss. These aren't just little side effects. These are things that determine whether or not your patient will actually take the medicine you prescribe. And beyond the common stuff, there are a few red flag reactions that are rare, but they are deadly, and you have to know them. Stevens-Johnson syndrome, or SJS, is a severe, blistering rash that is a true medical emergency. You have to tell your patients, especially when starting drugs like lamotrigine or carbamazepine, that any new rash means they need to call you immediately. That is absolutely non-negotiable. I'm showing you this quote again because this point cannot be overstated. Seriously. Remember this for your boards, remember it for your entire career. The risk that valproate poses to a developing fetus is so significant that for any female who could become pregnant, you just don't use it as a first option. You should be reaching for a safer alternative like lamotrigine or levetiracetam. And finally, you have to think like a pharmacologist. Some of these ASMs are bullies. They mess with other drugs. Carbamazepine, for instance, is an enzyme inducer. It revs up the liver's metabolism. You know what that does? It can make a patient's birth control pill completely useless. And that is a conversation you have to have. Valproate does the exact opposite. It's an inhibitor, which can cause other drugs to build up to toxic levels. And then you have others, like levetiracetam, that are cleared by the kidneys, so you've got to adjust the dose in anyone with kidney problems. The bottom line, always check for interactions.
Okay, let's take everything we've just talked about and put it all together into a clear, simple framework that you can use every single time you're faced with this decision. This is it, your 4-step framework for every patient. Step 1, classify the seizure. 2, choose the spectrum. 3, select the right drug based on the evidence. And 4, the most important step of all, personalize it. Is this framework simple? You bet. But following it rigorously is what separates a good clinician from a great one. It ensures you make a thoughtful, safe, and effective choice every single time. So, as we wrap this up, I'll leave you with this question to carry with you into your practice. What is it about your next patient that's going to influence your choice? Is it their job as a truck driver? Their desire to have children one day? Their kidney function? The other medications they're on? Answering this question, well, that's what elevates treatment from just a protocol to the true art of medicine.